firstly, I've got to say thank you to Zoe for giving me 1 week's notice to come up with something, because that was kind. So this is something about the microcirculation, which is where we are. It's sort of based on the stuff that I did for my MD, and I'm just trying to drag it out of long-term memory to come up with some kind of sensible conversation about it. But hopefully it's relevant and it should be fairly useful. Okay, why isn't this moving? Okay, so what we're going to talk about, a bit about what is the microcirculation, why bother monitoring it or measuring it, a little bit about thermal imaging, and then a bit about what I did for my MD and what results we've got. So some generic, basic regurgitated stuff on sepsis, which everyone always comes out at the start of every single paper written about sepsis in the world. So it's a significant worldwide health burden. It's attributable to 60 to 80% of deaths in the developing world. The diagnostic criteria for sepsis didn't really change a huge amount from their inception in 1991, and there's been 3 iterations of them since then, with the most recent in January 2016, although there've been a couple of updates since then. And essentially, it's termed as a life-threatening organ dysfunction due to a dysregulated host response to infection. Now, it used to be previously that sepsis was based on the SIRS criteria, which people have probably heard of, but that sort of went out when they updated the guidelines in 2016, and they came up with a new definition, which was this wordy definition plus the SOFA score. So any of you guys come across the SOFA score? Matt's nodding his head, so he's going to have to tell me what it is now.
It tells you what you already know.
Yeah. Okay, so do you know what it stands for?
Is it the organ frailty assessment score?
Yes, it's sequential organ failure assessment score. So basically, it's quite a complicated score based on all of these things. So we do use it on ITU. We use it for anyone who's admitted, and it's a way of looking at acuity of patients on the units. But in reality, it's not a very practical score because it's got lots of investigations that you don't necessarily always have the answer to, and it's quite complicated. And one of the big criticisms of Sepsis 3 was that when they designed it and looked at all the data, it really excluded a lot of low and middle income countries. And actually, when I've just said that actually 60 to 80% of deaths worldwide are from sepsis in the developing countries, yet they didn't include any of those people in the definition. And you can imagine if you're in the middle of Africa, the chances are you're not going to have many of these results to hand. So useful in some respects, not in others. So it's complex. So the slides are taking a while to change. It's complex score. The limitations of the new definition of sepsis are that the mortality is quite high at the point that you make a diagnosis. And the problem with any study or anything looking at sepsis is that it doesn't really reflect what's going on with the underlying pathophysiology. It all looked at the end point rather than what's going on underneath. Okay, so yeah, and the reason for that really is that it's a complex disease state, and that's because you've got a complex interplay between what all the infectious factors are, and they're numerous, and then all the different patient factors and their underlying physiology and pathophysiology, which leads to this dysregulated host response. You've got pro and anti-inflammatory mechanisms, pathogen-associated molecular patterns, which are things that are to do with the bugs, and damage-associated molecular patterns, which are things to do with the person. And then you've got these things called pattern recognition receptors, which are sort of the interplay between all of them. But the key thing is that it's all really heterogeneous, and that's why a lot of the studies looking at different therapeutic interventions in sepsis are all negative, because you're not really comparing apples to apples. Okay, so what is the microcirculation? So it is essentially what it says in the tin. It's the small bit of the circulation. So a dense network of capillaries and arterioles and venules where the diameter is less than 150 micrometers. It depends which book you look at. Some say less than 100, but let's go with 150. It's a place where most gas and nutrient exchange takes place at the level of the capillary, or there is some internal arterioles in terms of nutrients, and there's quite a bit of fluid shifts that happen at the end of the venous side, particularly in sepsis. Each arteriole divides into lots of clusters, and these are termed modules of capillaries. And one of the key things to think about is this concept of AVAs, which are arteriovenous anastomoses, which are muscular microvessels which connect arterioles to venules. Therefore, you can bypass the capillary, and that's important to remember for later down the line when we talk a bit about the skin. AVAs are chiefly associated with temperature regulation, and that's why they're important. Okay, so the density of capillaries within a tissue is totally dependent on the metabolic demand of the tissue that they supply. So if you think of things like myocardium, you've got really dense, a really high capillary density because they need to gas exchange and have nutrient transfer all the time, whereas other tissues less so. And the flow within these capillary networks within the microcirculation is dependent on the vascular resistance, which is determined by the arterioles, because they're the bits that have got smooth muscle in them. And they can either be termed to be open or closed. At a resting state, the majority of these capillary networks are closed, and then you get vasodilatation of afferent arterioles, and then they become open, which is where you can increase when you have an increased oxygen demand. And it's intrinsically controlled, so it's not controlled by your general sympathetic circulation or sympathetic system. It's controlled by local mechanisms, and there's something called the Baylis myogenic response. Anyone know what that is? It's one of these useless things, so I guarantee that most people remember this and nothing else about the talk because it's got an eponymous name, but actually it's kind of irrelevant. It basically means that you get arteriolar contraction in response to someone's blood pressure going up, and it's just one of those weird and wonderful eponymous things that you can get. But other things such as endothelial secretions, that's stuff like what does the endothelium release to control muscular contraction? The Royal can join in. Yep, endothelium, including the name. Nitric oxide, yeah. Yeah, the other one's prostacyclin, predominantly. Vasoactive metabolites, what are those? Do you think about an exercising muscle, what does it release? No. So hydrogen ions, potassium, adenosine is another one. And if you've got hypoxia, that is another vasoactive metabolite. Autocoids are all of the things like histamine, serotonin, prostaglandins, and then specifically for my interest is ambient temperature and how that controls the microcirculation. Okay, so what about in sepsis? So if you look at the underlying pathophysiology of sepsis, it's predominantly a disorder of the microcirculation, and it's been termed by lots of people as the motor of sepsis. It's what tends to cause people to become incredibly unwell, and it's the thing that will determine whether they get better or not. Okay, and we'll talk about that in a second. And there's lots of different things that can go wrong with the microcirculation in sepsis, but essentially you get things such as arteriolar hyporesponsiveness. So the smooth muscle doesn't contract anymore, irrespective of how much sympathetic things you throw at it. You get capillary dysfunction, so either because they're completely dilated and they don't vasoconstrict again, or you get things that block them, and that can be neutrophils, it can be clot, it can be lots of different things. You get protein leak, which people have probably heard of, and you get this concept of perfusion heterogeneity, which is normally because perfusion is all intrinsically controlled. If a muscle or a tissue needs more oxygen, it automatically vasodilates in order to get that. But when you lose that reflex, then you can't control it anymore. Okay, so you can't then determine where blood flow will go to. The key thing, or one of the problems, is that microcirculatory dysfunction isn't pathognomonic of septic shock. So you get it in other types of shock, and predominantly you can get it in hypovolemia. But the key thing is that in hypovolemia, the microcirculatory dysfunction you get tends to follow what their macrocirculation is doing. So they've got low blood pressure, the microcirculation doesn't work, but that's not true for sepsis. So even if you correct their blood pressure and things, the microcirculation can still be knackered, and that's why people can still die even when the numbers look normal. Okay, so yeah, some of the key things from a sepsis point of view and why we probably should be looking at the microcirculation as a target is because if you improve if you improve the macrocirculatory numbers, which is the third point down, it doesn't necessarily guarantee the microcirculation gets better, and we don't really know why that's the case. We know that if your microcirculation gets better with early resuscitation, you're less likely to have organ dysfunction, and patients whose microcirculation doesn't get better are more likely to die. But the question is, how do we measure it? Do we measure it? Do we already measure it? Do we measure it? Okay, so think about some of the things we do when we're examining patients that might determine what their perfusion's like. Yeah. Yeah, exactly right. So cap refill is a really crude way of looking at the microcirculation because you're compressing blood vessels and seeing how long they take to reperfuse, and that is determined by your microcirculation, which is obviously then determined by leads onto your skin. So you can classify how you can look at the microcirculation into different measures or methods, if you like. So you've got indirect measures, indirect methods, which are things looking at sort of tissue perfusion. So transcutaneous tissue PO2, which isn't the same as SAT, it's actually looking at muscle tissue oxygenation. So we use the NERS device that looks at actual oxygenation of muscle tissue. That's essentially what that's doing. You look at SVO2, tissue CO2, so you can do transcutaneous CO2, which is like a little patch that you put on, it warms the skin up and measures CO2 through your skin. Lactate is a measure of looking at the microcirculation, although it's really non-specific. And we've mentioned NIRS, so near infrared spectroscopy. You can then do direct methods, which are these things, concept of actually looking at the microcirculation specifically. So laser Doppler, which I know nothing about, and then video microscopic techniques, which is essentially using a specialized microscope to actually look at the microcirculation in situ. So we do have one of these within the department, which is something called the cytocam, which uses incident dark field imaging, where you essentially use a handheld microscope and you put it under the tongue and you can look at the microcirculation. It looks like that when it comes back. So those squiggly lines, and you can actually see red blood cells floating down it, and you can count them. And there's some computer software that will do it automatically for you. The other thing you can do is dynamic methods. These are things like vascular occlusion tests. So if you inflate a blood pressure cuff above systolic pressure and you wait for the hand to deoxygenate, you can then release the blood pressure cuff and see how long it takes the hand to reoxygenate again. And you can draw fairly specific curves that look at that over time. And most people, if you do that to us, you'd get a hyperperfusion period. So when the blood pressure goes up, your hand goes white. When you take it off, it goes red, and then it goes back to normal. And you can plot that. And you lose that hyper response in people who've got microcirculatory dysfunction. Okay, so what about the skin? So this is a bit of basic basic histology, which I didn't do particularly well at university, because I didn't go. But there's two distinct layers of skin, essentially split into the epidermis and the dermis, and there's 4 different epidermal layers, which you can read, but you don't really need to worry about. The dermal layers then got 2 further layers, which are the papillary and the reticular dermis, and that bit's important because that's where the underlying perforating blood vessels come through, and essentially form 2 different plexi. You've got the dermal and the subdermal plexus, and it's the connection between those 2 that let us regulate our body temperature. They're all divided into these things called angiosome, which is like a 3D box, if you like, of a blood vessel that supplies an area of the dermis. And one of the really interesting things about skin is how rapidly and how significantly you can change the blood flow through it. So it can either be down from 1 mil per 100 grams right the way up to 150. And that's how we can shift heat away from our core and regulate body temperature. Now, interestingly, I said earlier that most tissues and capillary density is dependent on the amount of metabolism that tissue does, but actually skin is pretty metabolically inactive, and it's got a lot of microcirculatory supply, but it's all to do with temperature regulation and nothing to do with oxygenation. Okay, so I've mentioned you've got superficial and deep plexi, and if you look at the way they're organized, you've got ascending arterial, so the arterial side coming up, and the descending postcapillary venules coming down. So it's like a counter-current mechanism, a bit like a renal filter. Except you've imagined rather than having a solute, you've got heat. So the more connections you make between those, the more rapidly you can lose heat from your core to the outside. Glabrous skin, which is skin that doesn't have any hair on, has lots of AVAs, so lots of connections between the arterial and the venous side where you bypass the capillaries, and that's why you can control heat or temperature really easily through that skin. And it has little basal tone. This bit is almost exclusively controlled by the sympathetic nervous system via the hypothalamus, which is important for temperature regulation. And interestingly, if you think about being in a thermoneutral environment, the sympathetic tone is really high, so all those AVAs are really tightly closed, so you conserve heat. When your body temperature starts to go up, all those AVAs open and you start to lose heat to the outside. Okay. So why is it important? So we said we already do a bit of clinical assessment by doing things like cap refill, etc. But we probably do this stuff as well, which is looking at temperature gradients. So we're always feeling people's arms to see if they're cold and do they warm towards the core, etc. But also looking at people's legs, so skin mottling. So we probably didn't see as much of this here until we started getting more non-cardiac patients. Now we see quite a bit of it in terms of septic HPB patients and renal patients, etc. But there's been quite a few studies by a group in France that looked at trying to quantify mottling. So if you start with a circle on the anterior knee and then extend it out up towards the groin, the further that circle expands out, the worse your outcome is. And if you've got skin mottling full stop, you're 4 times more likely to die if you've got sepsis. So it's good sign, but it happens quite late. So by the time you've got it, there's usually not a lot of things you can do about it. It's subjective because it depends on, we might see it differently. And you can't apply it in all patient groups. If you've got really, really dark skin, you can't see mottling with the naked eye. And realistically, the only people who do it are us. So by the time when you actually really want to see it or start looking for it is long before they get here. But no one else really does it. Okay, so can we see it earlier? So theoretically, it's possible. So thermal infrared imaging is it looks a bit like a digital camera, but I was just explaining to Richard, it's a bit more expensive. And it yeah, and it essentially detects infrared radiation in the across the whole infrared spectrum. But the bit that we're interested in is the long wave infrared spectrum, which is the bit that we emit heat in, i.e. humans. And the way that it works, if you think of a digital camera which has got an array with lots of pixels on it which detect light, a thermal infrared camera works in a similar way. It's got an array, but each one of those pixels detects infrared heat, and the amount of energy that pixel, if you like, detects changes its resistance. So it's not that the camera produces that pretty picture. That's the software that does it. It just gives you a number which is related to the amount of heat energy that the microbolometer has detected. And they're made of something called vanadium oxide predominantly, which is what VOX stands for. The software then converts that heat energy into a temperature, and then the software then changes that temperature into a color. That's why you get a picture. Okay, so it's just a pictorial representation of how temperature is distributed across the surface of an object. So this is actually a photo that I took of the top of a cup of tea. So if you look at the top of the cup of tea, it looks flat, doesn't it? But actually you can see that heat energy isn't actually distributed uniformly across the top. It's distributed in waves, which is why it looks like it's moving, even though it's not. Okay, so there's some important things to think about from infrared thermal imaging, though, which is why it's not perfect. It measures all radiation that's emitted from the surface of something. So the bit of the radiation that we're interested in when you're looking at humans in terms of the skin is the bit of energy that you actually emit. So the energy that comes from you, i.e. the bit that makes up your temperature, is what we're interested in. But the camera doesn't know that. It only detects all the radiation that lands on the microbolometer, and that can come from things that are either reflected or things that are transmitted through it. Okay, so for humans, it's actually not that much of an issue because there's a factor called emissivity, i.e. how much of the energy that's coming from the surface of something is actually coming from that object. Okay, and in humans, it's 98%. So you're pretty confident that all the energy that you're measuring from the surface of something is from that person. But that's my hand, and if you look at the ring on my hand, it looks colder than my finger does, but that ring is the same temperature as my hand. Does that make sense? Okay, and the reason for that is that the ring has a lower emissivity than my skin does, and therefore it's reflecting the ambient temperature that's in the air, in the sky around you. Okay, so if you were to measure the temperature of that ring with a thermometer, it would measure the same, but when you measure it with a thermal imaging camera, it looks colder. Okay, and that's where people can get caught out. But it is a really useful technique because it's non-contact, which is fantastic for the application that we want to use it for, and it's really, really accurate. So between each individual bit of the microbolometer array, it's less than 0.02 of a degree, so it's really, really accurate. And you can measure really, really small areas. So they tried to use it originally in airports during SARS back in 2003, but it's got quite limited use. So if you look at the thermal image on the screen, if you want to try and measure someone's core body temperature using a thermal imaging camera, you've got to essentially get 9 pixels in the corner of your eye. Okay, that's how you'd be able to measure it. And what they did was mount cameras on the ceiling of an airport and then shoot it down at people. So you're never going to measure it. The other thing is, if you look at the chap who's wearing the glasses in the background and then look at his picture on the screen,
Yeah.
you can't measure it at all. Okay, so it's essentially useless. So off the back of that, ISO came out with some standards which essentially set out how you would measure core body temperature using thermal imaging, and really this application doesn't work. Interestingly, they brought it back during COVID and tried to do the same thing, and it didn't work again. So, surprise, surprise. Okay, so what about using thermal imaging in sepsis? Well, there's not really been a lot of very many studies that have done it. There's been a few more since then, since this presentation was written, but there's not really a huge amount. So they did a porcine model of acute lung injury. Well, I won't tell you how they did it, but it wasn't very pleasant for the pigs. But what they did show was that as the pigs got sicker, their body temperature became more centralized. So where it was quite homogeneous to start with, as they started to become more shut down, the temperature came right back into the middle essentially, and they got cooler around the edges. And you can come up with this concept of core peripheral temperature difference. So if you measure the temperature, core body temperature, and compare it to a peripheral temperature, the bigger that gap is, the more sick you are, which makes sense, doesn't it? Because when we feel people's hands, if they're really cold and their core temperature is high, you know they're poorly. A group in Sweden looked at an unselected group of ED patients and did a similar thing using core peripheral temperature difference, but they did it on one thermal image. So they used the tip of the nose as the peripheral temperature. Did they? Oh, no, they did. So they used nose and fingertip as two different types of peripheral temperature, and they used the corner of the eye, so the medial canthus, to measure core temperature. And they again showed association between how wide that core peripheral temperature difference gap was, and demonstrated that it was associated with mortality, but the numbers who died were quite small because it was a non-selected ED population, so there was only like 9 deaths. So they couldn't really, and it wasn't powered to do that, but they extrapolated that anyway. Okay, so what did I do? Well, dossed about for a bit, but we did some things looking at vascular occlusion tests, so those tests where you'd previously measure a temperature. We did it using a thermal imaging camera and it worked. And we did some stuff doing thermal core peripheral temperature difference and trying to work out the best way of measuring core body temperature, and that was quite interesting. But the bit I'm going to show you about is thermal mottling, because that's quite interesting. So we did a prospective observational cohort study. What does that mean, Christine? Blank. Okay. And we essentially we collected 35 patients in each group. So we had healthy volunteers who were essentially members of staff, and we had patients with sepsis who were basically patients in ED, and then patients with severe sepsis who, to all intents and purposes, were the ones who were on noradrenaline. We used the sepsis 2 definitions because I'm really old and I started this a long time ago, and sepsis 3 wasn't even a thing when I started it, and that's the reason why. And don't worry too much about this, but really all it's showing is that the groups were well separated in terms of how sick they were, which is as you'd expect, because that's the way that we recruited them. And we got roughly what you'd expect in terms of sources of infection, so predominantly respiratory or abdominal, and with a few other bits and pieces knocking around. And if you look at the SOFA score at the bottom, it was 3.75 in the ones with sepsis, and it was nearly 10 in the severe ones, so there was separation between the groups. So we were confident we were looking at the right population. And there was some mortality, and it was probably a bit higher than what we expected. But again, it wasn't powered to do that. Okay, so what we did is, for all the patients, whether they were healthy volunteers or they were patients, they had a period of acclimatization, so they had to sit down for 30 minutes, which was easy for the patients because they'd been there for days. But the healthy volunteers had to basically lay down. They were exposed from their groin down to their ankle, and we left that for half an hour, and then we took an image using a thermal imaging camera set distance so we could compare the images between one another. And what we were essentially looking for was, can you see any patterns, full stop, in patients who are either well or ill? And can you see mottling before it's visibly apparent? I.e., can you see thermal mottling because you can measure really, really small temperatures before you can physically see them? And these are the kind of images that we got. So essentially, these are the normal images, and they follow with what you'd expect. So for this color palette, anything that is red is hot, and anything that is purple is cold. Okay, and there's a scale on the side, so you can see if it's white, it falls off the top, and if it's really, really black, it falls off the bottom. Okay, so these are images of the anterior knee, and you'd imagine in healthy, normal patients or participants, they would have more heat where there's blood vessels that are close to the cervix and less heat where there isn't, and that's essentially what we showed. What we did get, if you look at the images on the right, the one on the far right is someone with a really hairy leg. It just gives you slightly unusual pictures, which is fine when we're looking at them as humans, but if you try and get software to interpret that, it can't do it because it just gets completely confused by the fact you've got all these cold bits that aren't really cold bits, it's just hair. And that was a problem because we tried to use artificial intelligence to try and come up with a scoring thing and it didn't really work. Okay. What did we see in... Is it going to work? Yeah, okay. So if you think about the more severe group, so severe sepsis, you get a pattern which is sort of the reverse of what you see in normal. So they've got really warm area of their anterior, of their patella basically, which extends up in both up and down in both directions towards their ankle or their groin. So essentially the opposite of what you see in healthy volunteers. And in the ones who are really, really sick, you get this sort of extended cooling pattern, which looks like normal, but is significantly colder. And it sort of extends out in these concentric circles as they're sort of spreading out towards the groin and the ankle, sorry. And what we found in patients with severe sepsis is if they had this extended peripheral cooling pattern, they were significantly more likely to die. So that was quite an interesting finding.
Just match that. Concentric circles around the neck.
Basically,
Yeah.
But you've got to take my word for it, but you couldn't actually see anything on their leg.
No.
So you couldn't see mottling on their leg, but you could see it with the imaging camera, which is quite cool. And then what was really interesting is you can actually see mottling using a thermal imaging camera that you can't see with the naked eye. So these legs, we've got the digital images that are side by side with them, they just look like normal legs. But the patients who are septic by the sepsis 2 definitions, and they have mottling that you can see that's thermally apparent but not visually apparent. So that was quite interesting because that group, if they had mottling you could see with a thermal imaging camera but not visible on the leg by the naked eye, they were more likely to end up on ITU. So theoretically, if you could roll this out in some kind of usable way, you could actually pick up patients that were likely to get sick before all of the things we'd normally do to determine it. So that was quite good. What we also noted was if you got that extended cooling pattern in patients who were septic, they were very likely to die. So it was sort of a really early sign that they weren't going to do very well at all. That's all makes sense. It's just pretty pictures, really. Okay, so I suppose in summary, microcirculatory abnormalities are present in patients with sepsis, which we know, and they're basically the motor of it. They're the most important part, and we don't really measure it at the minute, and we probably should. And we know that if we correct what we do measure, which is people's blood pressure and heart rate, that doesn't mean that the microcirculation gets better, and that's bad. And there are some novel methods that we've got that you can look at the microcirculation, but we don't really use them. And infrared might be something that we can use in the future, maybe to look at it. Although it's a bit clunky at the minute. So it's my daughter looking really sugars when she was about 18 months old. She was livid. Any questions?
So about the blocking the for white and name was hyperperfusion, name was back to normal. Is that because of the microcirculation opening and then shutting again?
Correct. So
it's normally not open.
No. So if you occlude blood flow to something, all the blood vessels distal to that will all try and maximally dilate because they're essentially screaming that they want oxygen. Okay, so you get all those local mediators that we spoke about, things like nitric oxide, potassium, all that kind of stuff gets released. And that then causes all of those microcirculatory units to all maximally vasodilate. So when you look at the curve, it sort of comes along at a straight line and then it dips down quite steeply when you get a loss of perfusion. Then when you release the clamp, essentially, you get a big rapid increase and a hyperemic bit, sort of a hump at the top, and it comes back to the baseline. And if you look at this, how steep that reperfusion bit is, okay, so the flatter that reperfusion curve is, the worse the patient is. And in patients who are severely septic, they don't have that hyperemic response. So they get a flattened curve without the hyperemic bit because they just can't vasodilate anymore. So the way that they did it originally was using like the near-infrared spectroscopy thing. So the pads that you put on the legs, you can get a special one that you put on the hand. It's called the Inspectra device. So you put it on there and it measures the oxygen in your thenar eminence. And they essentially did it like that. So they'd put that pad on, they'd measure the oxygen level, they'd inflate the blood pressure cuff, and they'd release it, and they'd plot how long it took for it to reperfuse. The way we did it with a thermal imaging camera was we got some students at uni that we gave like £5 voucher to, which was worth it because it's really painful. We got them to put their hand out on a table, and then we inflated a blood pressure cuff above their systolic blood pressure for 2 minutes, which is quite painful because they're awake when you're doing it. And then we filmed it with a thermal imaging camera. And then we basically put a sample in the middle of the hand and then ran the video back and took the average temperature from that box continuously and then plotted it over time. And you get essentially the same thing.
I guess my question is, it's great and it looks good. Well, the implication for practice, you can't target my dreams. There's nothing to target.
What's the point?
Improving microcirculation.
Yeah, no, you're absolutely right. So that is the other side of it. The counter argument to that is that we know that the earlier you treat things, the better. So if you can see things before they're visually apparent, then that means you can bring treatment forward a step. Earlier treatment.
So earlier escalation to iron stress.
Yeah. Yeah. Yeah.
Okay.
But you're right, because they've looked at lots of things, because you would imagine that if you've got blood vessels that are blocking capillaries, if you've got clots that are blocking capillaries, you'd imagine that by getting rid of them, you'd improve the situation, and it makes no difference. And various other things, like they've looked at using things that block nitric oxide, it still doesn't make a difference. So we excluded anyone who had overlying infection of the area we were imaging. So the ones that were skin were either cellulitis in the other leg, and then we'd use the contralateral side to image. So yeah, there was lots and lots of exclusion criteria. So if you've got tattoos that on the area that you're imaging, that changes the temperatures that you see. Even simple stuff like we have to make sure that anything that's on your skin, so whether that's any cream or anything, totally changes how the emissivity of your skin. So what we did run into a few times was if you've got patients on the unit and they've got sweat, like they're sweaty or they've got clammy legs, the images are totally they don't make any sense at all, because as soon as you put water on the skin, the emissivity changes and it goes down, and therefore you start reflecting ambient heat rather than what the patient's actually got. So it was quite tricky. So there's loads of caveats to it, which is why it's not as easy as sticking a camera in the top of an airport taking a picture. Yeah, there is. So a lot of the evidence for using thermal imaging in medicine is to do with things like breast surgery and looking for abscesses and actually looking for breast cancers, because breast cancers are metabolically very active, so you can actually see them with a thermal imaging camera. And likewise for skin, they've done lots of things in terms of soft tissue injury. So people who've got Achilles tendon injuries, you can compare side to side and you can actually see the side that's injured. So there's been a lot of it used in musculoskeletal type things and in primary care type settings, but very little in acute care.
How did you who made the decision for, let's say, ITU admission?
It wasn't me. I think that's the key thing.
On what basis did they make that decision?
Yeah, so it's kind of comes back a bit to I don't know if the guys at the Royal heard that.
No, we didn't.
So Eka was basically saying, if you know that when you take an image, someone's got a picture that might suggest they're going to get sick, then who decides who's going to go to ITU or not? I think basically, essentially, what happened is that it's kind of to do with just research ethics in general. Is that I'm not part of the patient's care, so I was part of the investigating team. It had nothing to do with actually their care per se. They were just flagged up to me, and I did the images. So you've got to be a bit separate from that side of things. But also, I didn't analyze the images until much further down the line. So I didn't actually really look at them at the point that they were taken. So, and actually at the point that they were taken, even if I looked at them, I wouldn't have known what I was looking at. So yeah, that made it quite easy. I just put my hands up when it's not my problem.
So my name is Paul Aaron. I'll be talking about this study which was looking into rethinking cervical spine clearance in obtunded trauma patients. So basically, there's a Canadian C-spine rule, which is used to clear cervical spine in patients that have suffered traumatic spinal injuries, particularly to their C-spine, but that does not seem to be very applicable in obtunded patients, which is the very basis for this study. So it's more so the diagnostic and management challenge that comes into play in obtunded trauma patients that have suffered blunt traumatic spinal injuries, and the fact that there's just been an ongoing debate between balancing premature clearance and prolonged immobilization, as well as the diagnostic accuracies of the imaging used for this category of patients, and knowing fully well that this contributes to about 750,000 of cases worldwide. So the case really is, the thinking behind the study is, should we prematurely clear the cervical spine, then we expose patients to lifelong disabilities as well as economic impacts of that. And if you prolongedly immobilize this category of patients, leaving them on cervical collars for longer than normal, it poses challenge to airway management. There's also been said to be increasing intracranial pressure from impaired cerebral venous return, as well as the personnel required to log roll this kind of patient. So yeah, so the debate is really between standalone CT versus combined CT and MRI in terms of the diagnostic accuracies, and trying to find a balance between not missing a significant cervical spine injury and also not just allowing for prolonged immobilization. So they were hoping to answer this question as to what the most effective imaging method for C-spine clearance would be in obtunded trauma patients. So what it did basically was to search through several databases electronically over the period of a decade, which sort of reflects advancements in medical practice as well as the imaging modalities we'll discuss. So a total of about 1,458 records were identified, and these were screened for duplicates as well as studies that didn't particularly that didn't provide data exclusively for obtunded patients, and they were all eliminated and sort of left with about 64 articles that were then evaluated for eligibility. And using the inclusion criteria, 6 studies were included in the final analysis. So this is just a graphical representation of the breakdown, how these studies were excluded. And 6 was included in the study. 6 studies were picked up. So these were the inclusion criteria that the studies had met, 6 of them. So they provided data about patients that were about 16 years and older, most of the authors defined obtunded patients with mental status with GCS less than 15. And the quality of the CT spine was also put into consideration with easy thickness less than 3 millimeters or a minimum slice of 64 slices. That sort of showed through the skull base, through the upper thoracic spine. And the comparator was to be a C-spine MRI as well. So if the study was a peer-reviewed study, it was added as well, irrespective of the experimental design. So the studies were excluded if they didn't provide specifics for the CT scan, as well as the MRI, and everything from meta-analysis, commentaries, editorials, and letters were not also added. So most of the authors of these studies included in this meta-analysis defined clinically significant cervical spine injury as that which is requiring treatment, either surgical stabilization or orthotic replacement or a change in the management. This is not very clear, but this study was carried out in Canada, and all but one of the studies included in this review was from the United States. They were all retrospective cohort studies. And using the PRISMA 2020 guidelines and a random effect model, they were able to come up with a conclusion that overall, the mean negative predictive value of CT scans was about 93% in diagnosing clinically significant CSI. And it was about 94 for CSIs requiring treatment. However, amongst the patients that had negative CT scans for the C spine, about 269 had abnormal MRI findings, and about 6% of them, which accounts for 33 of the patients in the studies, had clinically significant CSI on MRI, and 31 of them required treatment. So this is a table showing the breakdown of all these bits. So particularly on Fisher et al., we could see that about 13 patients had significant CSI that wasn't picked on CT. Was very much that had negative CT, was very much positive MRI that picked this, and about 7 of them had significant intervention. In this particular bit, the Tan et al., even though there was no significant CSI, MRI still picked some sort of cervical spine injury that was regarded as insignificant, all of which required intervention somewhere along the line. So basically, there's high heterogeneity amongst the studies because they had different, there was no consensus as to how they defined CSI. So the overall risk of bias was moderate because they had 2 examiners looking into the studies. But the quality of evidence was low due to the retrospective nature of the included studies and high heterogeneity. So they assessed their risk of bias and quality assessment using Robbins 1 and Quarters 2. So this sort of gives a clearer picture as to the ratio of significant CSI to negative CT scans. So in all of the studies, except for Kana, you could see that certain amount of significant CSI was missed in patients that had negative CT scans. And this is showing the amount of this CSI that required treatment, just about the same number basically across both, except for Tan et al., where even though it was insignificant, those patients still required treatment along the line. So limitations to this study is just what I've said earlier, that there was no standardized reporting criteria for how to define CSI. And so there was considerable variation amongst the studies. And studies sort of centered around the younger population without factoring the older population and some of the degenerative changes in them that could affect the CT scan reports. So what do I think? Did this study answer the research question? It's quite equivocal. Yeah, they've shown evidence that there is a pooled missed rate of about 6%, missed CSIs in patients that had negative CT scans, but still very much limited evidence. And also considering the high degree of heterogeneity as to the fact that they didn't have a standardized way of reporting their CSI. So it's difficult really to go with them. And does it change or influence my practice? I'm in the UK, so particularly not, because in Northern Europe, it's probably a thing of considering the out-of-pocket cost for patients that require MRI after doing CT scans and then. But very much so, yeah, you could easily do a CT scan, and if it's negative and if there's still a high index of suspicion for cervical spine injury, we'll get it to do an MRI. So I think this is more like the tester in Northern Europe. They probably still need to do a lot more research with more standardized methods of reporting the CSIs to be able to come up with evidence-based conclusions as to what the best imaging modality will be for clinically significant cervical spine injuries in patients that suffered blunt trauma to the spine. Any questions?
How many MRI necks do you do at the Royal for patients who are obtunded?
I really don't know.
Think of all those significant injuries you've missed.
So I know in Queens we can't clear a C-spine unless the CT C-spine has been reported by a musculoskeletal radiologist. But there's no mandate there that you need to have an MRI, and I don't think that we particularly do look at MRI for C-spine injuries. I mean, we will do if they've got neurology, even with a normal CT, but it's usually by that point we can pound it out. I don't think it's a standard of care. In an obtunded patient, we would jump straight to an MRI. Unless you have, as you say, a significant index of suspicion.
Good stuff. Thank you.